We
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects, as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Good evening, one and all. I welcome you all to today's Navigate Medico CME program. Now, I would like to invite Professor Umesh Kapil sir, the Secretary of the National Academy of Medical Sciences, to deliver the welcome address. Over to you, sir.
Good evening to all of you. Good evening to all participants who have very kindly consented to join this Navigate program. My welcome to Dr. Uma Kumar. She is the founder, head department of rheumatology from All India Institute of Medical Sciences. She was my colleague for almost 30 years, and she has immensely contributed to the field of rheumatology. I must admit over here that the dedication which she has for the rheumatoid arthritis patient is outstanding. A patient of rheumatoid arthritis feels so depressed and so small within himself or herself that he is unable to think anything else except for the joint pains which he has. Ma'am has been very passionate to the department growth as well as to the patients who are coming and meeting her in the OPD. The large number of patients which we have of rheumatoid arthritis in Delhi and around, and even from far places, they are coming to ma'am for consultation and treatment. I must say that the field of rheumatology has grown immensely, particularly in the field of autoimmune disorders. And this is the one which needs more and more research and development. And Department of Rheumatology at All India Institute of Medical Sciences is pioneer in the country for research and finding out newer modalities of the treatment. The Navigate program which NAMS has started is essentially for the postgraduate students in different parts of the country. They do not have the facility of updating their knowledge. And what NAMS has decided to have the most eminent people who can teach these students on online by virtual method so that their knowledge can be updated. This Navigate program is also open to all those who are interested in asking questions from the eminent expert. I would like to say that today we have a theme of effective management of common autoimmune disorders, and under which Today we are going to deal with effective management of rheumatoid arthritis, and it's a very important area. And if you look at the way we have developed it, is essentially that we'll have about 45 to 50 minutes of presentation, and this would be followed by question answer session. We are going to also have some MCQs to be administered to the participants so that we are able to understand and appreciate the knowledge which they have gained from the presentation. Also, we are going to have feedback from all the participants so that we can improve upon and we can make these sessions more useful and interesting. I would like to put on record my most sincere thanks to Dr. Preeti and Dr. Jaswant, who are the faculty members of the Department of Psychiatry, who very kindly agreed to facilitate these Navigate program. And thanks again to all of you. And I must say that I understand from the Dr. Mr. Ravi that about 175 people have joined online on YouTube. That's a great number. And that speaks of the popularity of the uh, speaker as well as the importance of the subject which is being dealt today. With these words, I again welcome all of you. Over to you, Preeti. Thanks a lot.
Thank you, sir. Now I'd like to introduce the speaker for today's session, Professor Uma Kumar ma'am, who is the founder head of the Department of Rheumatology at AIIMS New Delhi. She had pioneered the concept of rheumatology daycare in India, and she had been the past associate editor of the Indian Journal of Rheumatology. She had also been the editor of textbooks Skin and Rheumatologic Diseases, and she has multiple awards and honors to her credit, which includes the National Award for Popularizing Science and Technology, the UNESCO Eminent Women Scientist Award, ARA APLAR International Scholarship from Australia, Japan College of Rheumatology International Scholarship twice, WHO Fellowship, Fellow of the National Academy of Medical Sciences, Fellow of the Royal College of Physicians, Zydus Oration, Holtman Oration, R.K. Jaluta Oration, etc. She has more than 162 publications to her credit. She has supervised nearly 42 MB students, 8 DM, and 11 PhD scholars. She had been a member of the National Science and Technology Innovation Policy 2020 Task Force and had been the editorial board member of international and national journals. She had also been the past president of the Delhi Rheumatology Association and had been the chairman and the member task force of Dr. NV Curriculum Committee in Clinical Immunology and Rheumatology, DSC, TBT, CDSCO, etc. It's a great honor to have you here, ma'am, and to listen to your talk. Over to you, ma'am.
Thank you so much, Preeti, for that kind introduction. At the outset, I would like to thank everyone who's there in NAMS, particularly Professor Sareen, Professor Umesh, for giving me this opportunity to share my views on rheumatoid arthritis. I'll just share my slides. I hope my slides are visible to everyone.
Yes, ma'am.
All right. I'll just make it small by the side. I can see the all videos. Yeah. So today, as you know, we'll be talking about effective management of rheumatoid arthritis. I'm not able to move my slides. Yeah, it goes now. Yeah, so in next 40 minutes, after briefly introducing the subject, I'll be touching upon the various treatment strategies, the extra-articular manifestations of rheumatoid arthritis, what factors decide the particular kind of treatment in these patients. There is a term called difficult to treat RA in today's time, so I'll be touching upon that, and finally giving some concluding remarks. Rheumatoid arthritis, as you all know, it's an inflammatory, chronic, symmetrical polyarthritis, which involves small joints of hands and feet, but involvement of large joint is no exception. 20% of the patients, they can present atypically with mono or oligo joint involvement, or they can have asymmetrical arthritis. But this particular disease is not confined to the joints alone as other connective tissue diseases. Here also we have extra-articular manifestations. As you can see the list, there are too many presentations in various organs. One, you must have come across skin nodules. Raynaud's is little less common. There are various kinds of pulmonary involvements. There's vasculitis, and sometimes these extra-articular manifestations mimic various other medical illnesses. Not only this, rheumatoid arthritis results in various multiple comorbidities like diabetes, hypertension, and multimorbidity is very, very common in patients with rheumatoid arthritis, where the disease is not controlled early in the process. Here you can see certain pictures showing splinter hemorrhage, periungual infarct, leukocytoclastic vasculitis, gangrene. These all are manifestations of vasculitic process in rheumatoid. And quite commonly you see nodules on patients' hands, which could be rheumatoid nodule, or they could be nodules resulting from methotrexate therapy. There are certain ways of differentiating the two. Here in rheumatoid nodules, they could be solitary, they could be multiple. Usually they are painless. They could be freely mobile or adherent to the periosteum. And they usually occur at the sites where which encounter friction very frequently, like extensor surfaces of the arm, fingers, occiput, heel, sacral prominences, etc. And nodules can occur in internal organs as well, where they quite frequently mimic carcinoma. Similarly, methotrexate-induced accelerated nodulosis, they are found in 8 to 11% of patients, and they can occur at any time, and commonly they are found after 3 months of methotrexate therapy over to 12 years of treatment. And they usually occur on the pulps of finger. They are not usually periarticular, they occur at the soft tissues, and they can develop very rapidly, and they can be painful. There are certain risk factors which predispose these rheumatoid arthritis patients to extra-articular manifestations: male gender, rheumatoid factor positivity, smoking, very severe rheumatoid arthritis, certain genetic markers, then epigenetic changes, and 786cc polymorphism. It was important to know about extra-articular manifestations so that it can be emphasized aptly that it is very important to examine patients of rheumatoid arthritis in great details. Otherwise, the extra-articular manifestations might get missed. Gone are the days when we had only steroids and methotrexate for the treatment of rheumatoid arthritis. Today, we have multiple weapons in our armamentarium, and we classify these disease-modifying anti-rheumatic drugs into two categories. We call them synthetic disease-modifying anti-rheumatic drugs and biologic disease-modifying anti-rheumatic drugs. And synthetic disease-modifying anti-rheumatic drugs are again classified into two: conventional synthetic disease-modifying, which includes methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. They are targeted synthetic DMARDs, which all of you would be aware of, like JAK inhibitors, which are used left and right these days. If time permits, I'll touch upon that individually. Biological DMARDs, again classified into two: the originators and biosimilars. Originators are innovator drugs, and there were many drugs like rituximab, anti-TNF, and tocilizumab, and biosimilars of all these drugs are available in the market these days, which are very cost effective. Again, my slides are not moving. I'm sorry, I'm not able to change my slide.
Just try to click on the slide again. Yeah.
I'll try to do from here next. Yeah, it works. Yes, here this is a very important slide with few words. Initially, patients with rheumatoid arthritis were treated as giving palliative therapy, and all of you understand what that is. But now we are targeting to achieve remission in these patients, which means having virtually no disease activity and patients leading normal life. So the current concepts guiding treatment decision these days is early diagnosis, treat to target strategy. And target is remission, which means virtually no disease activity or low disease activity, and tight control of disease activity, which is defined as the treatment strategy tailored to achieve a predefined target within a reasonable period of time in an individual patients with rheumatoid arthritis. And the highlighted words are very important: to achieve a predefined target, which remission, if not remission, then low disease activity within a reasonable period of time, which can vary patient to patient, but usually that is taken as within 6 months. And as all you understand that development of rheumatoid arthritis is a dynamic process. It never happens that patient develops arthritis and develops deformity simultaneously. So it gives us the window of opportunity where we can intervene and prevent the damage to the joints. This just to show you that a meta-analysis which was published in 2006 has very clearly stated that even the delay of few days and few weeks result in separation of the line here in the picture, which shows X-ray damage. In patients where the treatment was delayed, there was more radiological damage in comparison to patients who received early treatment. Initially, we had difficulty in diagnosing these patients early because criteria required presence of radiological findings, but now we have ACR EULAR 2010 classification criteria. It's very important to remember that we have only classification criteria. We do not have diagnostic criteria for rheumatoid arthritis. Therefore, even if patient is not satisfying the criteria and everything is favoring the diagnosis of rheumatoid arthritis, patient can very well be labeled as rheumatoid. And like any other connective tissue disease, rheumatoid arthritis also remains the diagnosis of exclusion. There are many diseases which mimic rheumatoid arthritis. Even the presence of rheumatoid factor in very strong titers have been reported in other diseases. So if more than 6 criteria are present, this is definite RA, and a patient may not have criteria satisfying the diagnosis of rheumatoid. In retrospect, if it fulfills, then also patient can be labeled as rheumatoid, or in prospectively, is patient develops various other manifestations, and cumulatively, if the criteria are fulfilled, patient can be labeled as rheumatoid arthritis. So it's not about just the presence of small joints of hands. Even the large joints are given some score, and that is added to make the diagnosis of rheumatoid arthritis. Similarly, for serology is measured in whether that is present in low titer or the high titer, symptom duration less than 6 weeks or more than 6 weeks. So based on these defined parameters, we are able to diagnose these patients of rheumatoid arthritis. Then if we have diagnosed them, we need certain objective measures to assess the disease activity. Initially, what used to happen, and even now we see the prescription writing, patient is doing well, disease is active. I understand in the busy clinic, it's not always possible to calculate the disease activity, but that is the ideal way of doing it. If one is not able to write or calculate the scores, can actually write tender joint count, swollen joint count, and even early morning stiffness. And ESR and CRP, anyway, we have from patients' investigation reports. To assess the disease activity, we have simplified disease activity index, we have clinical disease activity index, we have DAS score, ESR, and DAS CRP. Then there is a very strict definition for remission, which is Boolean ACR Euler remission criteria, where as like no joint involvement is taken as remission, and different scores are given for classifying disease activity into various states like remission, low disease activity, moderate disease activity, or high disease activity. This is just to show you, people think that it's rheumatoid. Oh, patient can take painkiller and go back home. But cardiovascular diseases affect individuals more. It's true that there are emergencies in cardiovascular diseases, but not in rheumatoid usually. But look at the quality of life of rheumatoid arthritis patients. The inner red line shows the quality of life for rheumatoid, and other yellow and purple line shows myocardial infarction and chronic heart failure related quality of life. Definitely quality of life is poorest of all in patients with rheumatoid arthritis when we compare it with other patients with other ailments. Similarly, here you can see in patients with remission, that means where the disease activity was absent, patient had the best quality of life, which is shown by the blue figure. Now, to achieve remission or low disease activity, what strategies we have? For that, we can follow any. Like one is step-up approach, another is parallel approach. Parallel approach is giving 2 or 3 drugs together. Then when we are giving 2 drugs together, the conventional synthetic DMARDs and biologic DMARDs can be combined, or various conventional synthetic DMARDs can be combined together. So it could be sequential monotherapy, like patient is started on methotrexate and they did not respond at 3 months or 6 months, then patient is put on another conventional synthetic DMARDs. Then combination therapy, I said step-up combination upfront. Upfront is giving all 2-3 drugs together. Step-up is going one by one. Here, the methotrexate is the sheet anchor drug for managing rheumatoid arthritis. There are certain things which are very important to know, like what dose to start with. Here, we go with 25 milligrams, or one can say 20 to 25 milligrams per week. We do not start patient on 5 milligrams or 7.5 milligrams. There is literature which is available which says that patient can be started on 15 milligrams of methotrexate, and then gradually every week or 2 weeks, dose can be stepped up by 5 milligrams. That increases the tolerance. But here at AIIMS, we upfront go with 25 milligrams of methotrexate every week with folic acid. We do monitor these patients for adverse effects, and to maximize the efficacy, that means if patient is on 25 milligrams of methotrexate, so we know that when the dose goes beyond 17.5 milligrams, the gut receptors, they get saturated, there are bioavailability issues. So one can split the dose of methotrexate, but it's to be taken the same day, 8 to 10 hours apart, or patient can be started on parenteral methotrexate, subcutaneous or intramuscular. That reduces the gastric adverse effects and also increases the bioavailability of the drug, making it more efficacious. The response of the methotrexate be assessed at 8 to 12 weeks, not before that. So don't be in a hurry to add another DMARD or biologic or steroid just at 2 weeks or 3 months, 3 weeks after starting methotrexate. As I mentioned, treat to target, and target we all know. Then tight control of disease activity is very important concept in the management of rheumatoid arthritis, which means that treatment strategy is tailored to the disease activity of an individual with RA and achieving a predefined level of low disease activity within a reasonable period of time. Again, that is a repetition, but that is very, very important to understand, because that decides when to add another drug and when to call patient for follow-up. We have good quality data to support what I am saying. We say that combination synthetic DMARD therapy is at par with biologic combination. But if we take this in totality, then conventional synthetic DMARD combination therapy is better than biologic combination, because one, we are reducing the adverse effects. Second, it is cost effective. These are the landmark trials, Ticora trial, best study camera. They have proven beyond doubt that there had been no difference whether patient had been on conventional synthetic DMARD therapy to control the disease activity or combination of conventional synthetic DMARD and biologic started early in the long term. And what we are concerned about is the long-term outcome of our treatment strategies. So it really didn't make any difference in these trials that whether in the long-term combination synthetic DMARD was used or biologic with conventional synthetic DMARD was used as the initial therapy. What is more important is early and aggressive treatment approach, as we are talking about treat to target and tight control of disease activity. This is a little complicated graph, but as you can see here, that in patients who were methotrexate naive had better response with biologics when added. This is methotrexate naive, and this AGREE trial was, this is methotrexate, can you, pointer is moving, I think you can see this. Methotrexate naive AGREE trial, you can see here also, you see these are methotrexate naive patients, and the response has varied from 16 to 25%. But in these patients, when various biologic agents were added, you can see the response was better in patients who had partially responded to methotrexate than in patients who were just refractory to methotrexate. Another take home from this slide is that there was no difference in the response whether patient was, which biologic DMARD was added to the patient in who were methotrexate refractory. Definitely there was marginal benefit which did not reach to statistical significance between biologic DMARDs and JAK inhibitors in patients who were biologic refractory or had partial response with the addition of biologic drug. So just to summarize what previous slide concluded, because that was very important, in methotrexate naive patients with early RA, methotrexate monotherapy had shown good response up to 25%. Those who insufficiently responded to TNF inhibitors, the other mode of action agent is not more effective than treatment with another TNF. That means the understanding previously was that patients who had secondary failures to TNF inhibitor, if they are given biologic with another mode of action, for example, rituximab or abatacept, they would respond better than adding another TNF inhibitor. That concept no more exists. Targeted synthetic DMARDs show a numerically somewhat higher response than biologic DMARDs in patients who have previously failed biologic DMARDs, and also in patients who have failed TNF inhibitors responds less well to other biologic and targeted synthetic DMARD than those who have failed methotrexate. There are various factors which decide the choice of DMARDs, whether patient is planning for pregnancy, whether patient has presence of extra-articular manifestations, because there are certain drugs which are to be avoided in interstitial lung disease. But remember, methotrexate is no more contraindicated in patients with interstitial lung disease. And that concept that methotrexate causes interstitial lung disease in rheumatoid arthritis does not hold true. The recent study had shown that it is the inflammation which is resulting in interstitial lung disease rather than methotrexate, because patients who were on methotrexate and responded to it and their disease activity was controlled, the prevalence of interstitial lung disease was less. Depends on comorbidities, whether the patient has hypertension, dyslipidemia, coronary artery disease, CKD, or malignancy. Suppose patient has dyslipidemia, then we'll be very careful in giving those patients JAK inhibitors or tocilizumab. The drug interactions are to be kept in mind. History of tuberculosis is very important. It's better to avoid anti-TNF in patients who had tuberculosis, but they are not contraindicated. Rituximab is a better choice in patients having history of tuberculosis. Then presence of certain poor prognostic markers are to be kept in mind. They are persistently moderate to high disease activity despite conventional synthetic DMARD therapy, high acute phase reactant levels, high swollen joint count, presence of seropositivity, that is rheumatoid factor and ECPA, presence of early erosions on X-ray, and failure of 2 or more conventional synthetic DMARDs. And ultimately, patient preference is the most important. There are many patients who are not willing to take multiple drugs, who are not willing to take any injection. So that also has to be kept in mind while deciding on the therapy. And the financial status, because affordability of our set of patients is not that good. Many, they cannot afford biologics. They are to be managed with low-dose corticosteroids and available conventional synthetic DMARDs. When we prescribe patients biologic DMARDs, there are certain poor predictors of remission which are to be kept in mind. They are like old age, female gender, smoking, obesity, poor nutritional functional status, high disease activity, prior treatment failure to the biologic or the combination DMARD, the greater disease duration, established RA responds less well to biologic DMARDs than recent onset RA, and very high inflammatory markers. And there are chances of getting remission in patients. That means favorable markers like younger age of onset, male gender, fewer extra-articular manifestation, fewer comorbidities. And patients who were given obviously biologic targeted synthetic DMARD prescription, there will be more chances of patient achieving remission. When to adjust the therapy, that is also very important. As you had seen that we have multiple drugs available for treatment of these patients, always remember to prescribe conventional synthetic DMARDs as the first line therapy, biologics at second, and third comes JAK inhibitors. If there is no improvement by at most by 3 months, and improvement has to be more than 50%, right? And when we are assessing the disease activity in patients, and then one can think of treatment target is not achieved within the subsequent 3 months. That means treatment will not be escalated if the treatment target is nearly fulfilled or the comorbidity or the other safety issues preclude such a step. For example, if patient had disease activity, there had been at 3 months when you assessed, it has not responded completely to the treatment, but patient has associated coronary artery disease, or patient has uncontrolled blood sugars, severe diabetes, or some other comorbidity that can deter us from adding another agent to the treatment. Or if the patient is intolerant to the particular drug, then we need to adjust the therapy in patients. How frequently to monitor these patients? It is said that every 8 to 12 weeks, we need to repeat hemogram, LFT, and kidney function test. But in patients who are on JAK inhibitors, lipid profile also is to be monitored, and so is patients who are on tocilizumab or which is available with the name of Actemra, you must have heard of. Once the desired treatment target is achieved, one can follow up these patients less frequently. That could be 6 monthly to 12 monthly. There are guidelines for screening patients with rheumatoid arthritis where biologics are planned. So we do TB screening by doing IGRA and MANTU also, and chest radiograph, and history of tuberculosis in the past is also to be taken. Also, history is suggestive of tuberculosis in the current times. Viral markers, HIV, Hep B, and Hep C serology. Lipid profile, if we are again trying to give patient tocilizumab and JAK inhibitors. IgG levels are done if rituximab is planned in patients, besides the routine investigations which are to be done. Just to touch upon the ACR, URAR recommendations for managing these patients. Here, if diagnosis of rheumatoid arthritis is made and there is no contraindication for the use of methotrexate, start methotrexate in the doses of 20 to 25 milligrams per week along with folic acid. If patient has severe disease activity or is not able to carry out routine work, low-dose corticosteroids can be added to the treatment. And if there is contraindication to the methotrexate, then other drugs like leflunomide or sulfasalazine can be added. Hydroxychloroquine is a very weak DMARD, so patients should not be only on hydroxychloroquine. We do not use that drug upfront in patients unless there are contraindications to use of other conventional synthetic DMARDs. Then patients are assessed at 3 months. And if the patient has achieved the target of 50% response at 3 months, then the treatment is continued and patient would be assessed again at 6 months. If patient has responded, continue the treatment. But if there had been no response and there is presence of poor prognostic factors, as I have described, and to repeat it again, like high rheumatoid factor, anti-CCP antibodies, high disease activity, joint erosions, and there had been failure of more than 2 conventional synthetic DMARD, then add biologic DMARD. It mentions that, but in the second phase, the second DMARD, conventional synthetic DMARD, can be added. And these biologics are given only when patient fails 2 or 3 conventional synthetic DMARD. But in certain situations where there's no problem of affordability and patient can easily take it, we sometimes do add biologic DMARD as a at 6 months in patients who have just not responded to methotrexate. If there are poor prognostic markers, again, one I have to think of adding biologics or JAK inhibitors. Patients are assessed at 3 months, and if there has been a response, continue the treatment. If there have been no response, then we again need to switch between the biologics. But adequate time is to be given to patients so that they can show the optimal response to a particular drug. One should not be in a hurry to switch biologic DMARDs or conventional synthetic DMARDs or JAK inhibitors. There's a word of caution that JAK inhibitors should not be used left and right because there are very serious adverse effects involved. The recent publication has very clearly and categorically mentioned that they increase the risk of coronary artery disease and cardiovascular problems in patients where they are used. Also, the risk of malignancy is increased in patients who had been on JAK inhibitors. Now the question arises, are we able to stop drugs in patients who have achieved remission? The answer to that is no, because whatever little data is available, the patients who had achieved remission or low disease activity for some time and they were put off drugs, then it was seen at 5 years, only 11 to 18% of the patients, they remain in remission or low disease activity. They all had relapse of the disease. So it's always better to de-escalate the treatment very gradually. What we do here, we let the patient be in remission or low disease activity for at least 18 months to 2 years, and then we gradually de-escalate the treatment. Yeah, and I don't remember many more of my patients being off treatment, but there are patients who are continuing and doing well just with 7.5 to 10 milligrams of methotrexate only. And now coming to difficult to treat RA, there is a definition, ACR EULAR definition for difficult to treat RA. This includes not only patients with active joint disease, but patients who are not feeling well or they continue to complain of pain in their joints are also included under this category. So one has to be very, very careful in making out whether patient has any evidence of disease activity or not before stepping up the treatment which patient is already on. And the important point here is to remember that patients who have not achieved low disease activity or remission or remain active despite being given two biologics with different mechanism of action or a biologic with targeted synthetic DMARD. Then rheumatoid arthritis in pregnancy is to be dealt with very differently. There are certain drugs which are to be avoided, completely contraindicated in patients with pregnancy. I'll try to explain it with this case scenario. 23-year-old female, history of rheumatoid arthritis with high disease activity. DAS score was more than 5.2, was on methotrexate along with folic acid. At 6 months, she did achieve remission and she got married, and now she has plans to start her family. And now what to do? So just to show you this chart, obviously we'll start methotrexate, and these days it said that methotrexate is to be stopped 4 weeks prior to the conception. And during pregnancy, there are certain drugs which can be given. Yes, this is the slide. Hydroxychloroquine, sulfasalazine can be safely continued during the pregnancy. Colchicine, azathioprine we don't use. And then low-dose prednisolone can also be given to control the symptoms. The initial concept that patients of rheumatoid arthritis, they go into remission during pregnancy does not hold true. Patients do have a flare of disease during pregnancy. And as you can see here, amongst biologics, all drugs in that category of anti-TNF inhibitors can be given through the conception, that is preconception, during conception, and then rituximab is to be discontinued. That cannot be given during pregnancy until unless there is very compelling indication for giving that. And this pink area shows that these drugs are contraindicated during pregnancy. Methotrexate, leflunomide, mycophenolate, we don't use in RA. Cyclophosphamide also, we don't use it in RA, except in certain extra-articular manifestations. And methotrexate is to be stopped 4 weeks prior to conception. And if patients are, leflunomide ideally should be avoided in any lady in reproductive age group. But if lady plans to conceive, then cholestyramine washout has to be given. Tofacitinib, apremilast, baricitinib should not be given to the patients during pregnancy and is to be stopped 4 weeks in advance. This is another case scenario where 45-year-old male, normotensive, non-diabetic, seropositive RA, on methotrexate and leflunomide develops paresthesia and numbness of toes for 2 months. She was pale, disease activity wasn't there, patient was in remission, there was no neurological deficit, plantar flexors. Nerve conduction velocity has shown a sensory motor neuropathy. Patient denied nerve biopsy. A possibility kept in these patients were drug-induced neuropathy. Leflunomide is known to cause this, or vitamin B12 or folic acid deficiency. Patients can be folic acid deficient because they are on methotrexate, or vasculitic neuropathy. Yeah. About this leflunomide-induced neuropathy that usually occurs after 6 months of leflunomide use. It is usually distal, axonal, sensory, or sensorimotor. Any of the forms can occur. Recovery is better if leflunomide is stopped within 30 days of neuropathy onset. So one has to be very careful while giving this drug if the patient starts complaining of neurological manifestations. Mostly the onset of neuropathy is during the period of controlled disease activity, and nerve biopsy does not show vasculitis. Regarding folic or B12 deficiency, which is usually slowly progressive polyneuropathy with predominant lower extremity involvement, large fiber axonopathy without segmental demyelination, there's a tendency to manifest as sensory rather than motor neuropathy. And on a peripheral smear or in RBC indices, macrocytosis could be a clue for this type of neuropathy. So in this patient, we thought maybe patient has leflunomide induced. We stopped leflunomide. Pregabalin was given to patients. Vitamin B12 and folate was also supplemented. After 2 weeks, patient had 20 to 30% relief in neurological symptoms, but patient developed palpable purpura, both lower limbs. And then patient also had fatigue, low-grade fever, has active disease, and patient was started on low-dose corticosteroids. Patient went back, again came back with left foot drop, pain right second toe. Patient at this point of time was given IV methylprednisolone pulse for 3 days, and also patient received cyclophosphamide. Patient responded, and there was no progression of neurological deficit. So you can see how difficult sometimes it is to manage these patients of rheumatoid arthritis. In this case, just highlights not to ignore patient's manifestation, be very vigilant and careful. So this patient had rheumatoid arthritis associated vasculitis, which was proven on nerve biopsy and skin biopsy, and subsequently this patient got the biopsy done. So at 3 months on cyclophosphamide and prednisolone 10 milligrams, patient developed deep cutaneous ulcers on both legs. Steroids were stepped up and patient was started on rituximab, to which this patient responded and doing well till now. So vasculitic ulcers, they are more common in lower extremities, and they characteristically occur at the dorsum of the foot or the proximal to the ankle, unlike the ulcers which are secondary to atherosclerosis. So a word about rheumatoid vasculitis, which rheumatoid vasculitis remains the diagnosis of exclusion, because if the patient is having rashes, having fever, other conditions are also to be kept in mind. And there are certain surrogate criteria for making the diagnosis of rheumatoid vasculitis, which are like presence of classic ischemic skin lesions, monocytic multiplex in a patient with established RA, and we are not finding any explanation for these findings. And cutaneous vasculitis and multifocal neuropathy, low C4 are the predictors of worst prognosis in these patients. It's not a common presentation in our patients. It can happen in any age, more common in males, and usually occurs in long-standing disease. So if the patient is having rheumatoid factor positivity, polyarthritis, and developing ulcerations, always think of some other conditions where patient can have vasculitic lesions in the very early disease, or that is the presenting manifestation of the disease. Severe RA with deformity, skin is commonly involved, nervous system gets involved in 40%, eye in 60%. Scleritis, we do see in patients. In some of our patients, they ended up losing their eye because they were very careless, ignorant about it. So one must keep these manifestations in mind. So extra-articular manifestation do have predictive value for the outcome in rheumatoid arthritis. And those who have extra-articular manifestation are more prone to develop comorbidities over the period of time. And they are usually known to have a very active, aggressive course of rheumatoid arthritis. So I'm reaching towards the conclusion. The most important thing is shared decision making in any patient for that matter, but more so in our patients, because the drug cost is huge in the treatment and there are many, many options available. And the treatment decisions are usually made based on disease activity, progression of structural damage, drug safety, comorbidities, extra-articular manifestation, and affordability of the drug. So treatment of rheumatoid arthritis is not individualized at the molecular level, but personalized at clinical level. This is very important statement, that you are not treating rheumatoid arthritis or IL-6 or TNF alpha, and we are treating patients in totality. And there are other parameters to which improve the quality of life in these patients, that is also is to be taken care of. Methotrexate is a sheet anchor drug in rheumatoid arthritis patient. Combination conventional synthetic DMARD strategy is non-inferior to combination of conventional synthetic DMARD and biologic. And tight control of disease activity is more important than thinking about various combinations of drugs. Avoid frequent cycling of drug, which means that if patient is started on methotrexate, came to you at 4 weeks, and you thought that patient is not responding, and then leflunomide is added, or patient is given steroid, or methotrexate is stopped, patient started on tofacitinib, given for 4 weeks, patient did not respond. So all these things should not be done in the management of rheumatoid. And steroids are used for the shortest possible time, but they are not bad drugs if they are used very judiciously. In certain extra-articular manifestation, as you saw in that case scenario, we did give patient pulse methylprednisolone. Intra-articular injections are given to these patients. Suppose patient has responded well, but only one joint is active, that joint can be injected with intra-articular injection rather than stepping up the treatment with available disease-modifying anti-rheumatic drugs. Or if patient had a flare in between, then short course of corticosteroids may be tried, because now we have started talking about, are we over-treating our patients? Because as we know, all autoimmune diseases have a trigger. So when the trigger goes, the disease might again go to relapse, remission, or patient can switch to disease with low disease activity. So therefore, it's very, very important to tide up that period of flare of the rheumatoid arthritis, which maybe with short courses of corticosteroids, rather than jumping on to add another disease modifying anti-rheumatic drug or putting patient on biologic. But this treatment depends on the very presentation of the patient and varies case to case. Thank you so much. Well, hello.
Good evening, ma'am. Yes, ma'am. Requesting all the participants to pose their questions in chat or raise their hands. There is a question in the chat. Ma'am, if hydroxychloroquine is a weak agent, what about tablet chloroquine? Because I have seen some prescriptions with chloroquine for rheumatoid arthritis. Role of anti-CCP antibody in the diagnosis or prognosis of rheumatoid arthritis. Okay. There are multiple questions. We'll take up one by one.
Yeah, regarding, yes, the first question regarding hydroxychloroquine versus chloroquine. Hydroxychloroquine is supposed to have less gastric side effects. Initially, when hydroxychloroquine was not available, we used to use chloroquine in patients with rheumatoid arthritis. Then the role of anti-CCP antibodies in the diagnosis and prognosis. Yes, anti-CCP is very specific for the diagnosis of rheumatoid arthritis, supposed to be to the tune of 96%. But we do get anti-CCP positivity in other diseases also, like in psoriatic arthritis. It does help in prognosticating the patients, because patients who are seropositive and have both positive rheumatoid factor anti-CCP, they are known to have worse prognosis. By using the term worse, I mean that it's not on treatment. They should be treated more aggressively.
There's one more question. Steroids for a short period, how many days minimum and maximum?
Look, this is a very good question and also a very difficult question to answer. But if we look at various guidelines and recommendations, they say it are to be used for the shortest possible time, not more than 6 months in the entire treatment period of the patient, right? But it all depends what is the indication for giving steroids. So it should not be given routinely to all the patients. Steroids act as a bridging therapy, and that helps in building the confidence of the patient on the doctor, that treat immediate response, because all DMARDs, they take some time to show their efficacy. And then if we are giving it for any of the extra-articular manifestation, for interstitial lung disease or vasculitis, then it is given for a longer period of time and maybe in a higher doses. So what we do at our place, we know that if we give patient oral corticosteroids, and they'll feel benefit and they'll keep popping the pills. So therefore, I prefer giving patient injection methylprednisolone 80 milligrams intramuscular every week for 2 weeks and a maximum for 4 weeks. So if you need to use short course of steroids at a stretch, don't go beyond 4 to 6 weeks.
There's another question from Dr. Sumit. Good evening, ma'am. How to choose for late onset rheumatoid arthritis?
Like late onset, Dr. Sumit is my senior resident, and late onset rheumatoid arthritis, I think he means that if the patients, those developing the disease beyond 60 years of age, in that age, we have to be very, very careful in choosing our drugs, because those are the patients who have multiple comorbidities. That's one. Second, late onset RA patients or elderly onset RA patients, they respond very well to low dose to corticosteroids if they are given in for a shorter period of time. And further, there's no very hard and fast rule that they will not go in for aggressive disease. So one has to be very judicious in treating those patients. And one can avoid drugs like JAK inhibitors, because they can cause dyslipidemia and have major cardiovascular adverse events. And even anti-TNFs can be avoided in those patients if other options are available and patient agrees to take that.
Another question from Dr. Abhishek. Good evening, ma'am. When to stop and restart disease-modifying anti-rheumatoid drugs in elective orthopedic surgery?
When to stop and restart demand in elective? Yeah, in elective orthopedic surgery, one need not to stop the conventional synthetic DMARD. Even methotrexate is not stopped. Leflunomide can be stopped in these patients because that is known to increase the risk of infection. So leflunomide can be stopped in these patients and can be restarted once the wound heals. But regarding biologics, yes, all biologics are to be suspended during that perioperative period. In anti-TNF is stopped 4 weeks in advance, 2 to 4 weeks in advance, and same is for rituximab, and they are to be started once orthopedicians or the physician is satisfied with the wound healing.
There are no more questions as of now, ma'am.
Madam, regarding the seronegative, we have a big tough time in treating seronegative arthropathy?
Yeah, people do use that term seronegative arthropathy or seronegative RA for that matter. But first is my personal viewpoint that I always feel that all our patients, they evolve over the period of time. So any patient who is coming with polyarthritis and with significant early morning stiffness and fitting into that criteria of rheumatoid arthritis, but RF and TCCP negative, I'm more comfortable labeling that patient as chronic undifferentiated inflammatory polyarthritis. Maybe this patient develops psoriasis after some time, after a few months or after a year, or this patient develops some other manifestation like sarcoidosis can mimic this. Some patients have evolved even paraneoplastic manifestation. I have seen patient turning out to be a case of lymphoma after 3 months or 4 months. So, but yes, what I do if I'm labeling these patients as chronic undifferentiated inflammatory polyarthritis, and the duration is very short, in few months, I prefer using sulfasalazine and hydroxychloroquine with low dose corticosteroids rather than giving methotrexate and leflunomide. But yes, that does not mean one cannot use it. So why I don't use it, I've explained to you. And I'm more comfortable in treating patients with biologic and other drugs where disease is a few months and or years old. And even if RF and TCC negative, yeah.
Are there any Indian guidelines for treatment of rheumatoid arthritis which has formed?
Indian guidelines for management of rheumatoid arthritis, yes. Long ago, Indian Rheumatology Association has formulated a guideline for managing rheumatoid arthritis.
So in this era of precision medicine, selection of drug in rheumatoid arthritis, is there any precision role which is taking place? We can select particular drug for particular subset of patients.
No, actually, rheumatoid arthritis is not so simple a disease as it seems with the name and the kind of description which is given in the books. Till date, no precision medicine had worked, or I think would work. It's a long way to go because this is a polygenic disease. So in polygenic diseases, and it's not the one cytokine or one cell which is active. It's a very complex process, etiopathogenesis of rheumatoid arthritis, which I deliberately did not touch upon because it was management only we were focusing on. So till date, no precision medicine for these patients. One drug which we expect it to work in a particular patient, but doesn't work, and where we don't expect that drug to work on, it's working despite doing extensive evaluation in terms of clinical and lab.
There are so many patients will be seeing coming with a bone scan. Is there any indication for bone scan in rheumatoid arthritis?
No indication for doing bone scan in rheumatoid arthritis because there would be increased uptake of scan in it at any site of inflammation. So if the joints are inflamed, clinically we are able to see this. But yes, sometimes if a patient is complaining of pain, but we are not getting objective evidence of inflammation, no tender joints, no swollen joints, in that scenario, sometimes this can help if we find increased uptake. But again, that can be false positive because studies have shown that those manual workers and people with the joints are used more frequently, there is some amount of subclinical inflammation. And ultrasound is a better modality than bone scan to pick up erosions and inflammation in joints. Musculoskeletal ultrasound.
There are two questions in the chat. One is by Dr. Sachin. Good evening, ma'am. Do we need to do both TST and IgRA to screen for latent TB? If either is positive, how to approach?
Yes. although majority of the studies they mention about IGRA, but by doing 2, we are on the advantageous side. So if the IGRA is done and that is negative, one can do the TST. If any of the 2 positive patient, and there's a way to do the TST also, it shouldn't be just for the sake of doing. There is a way to do that. And if it is negative, it is also recommended it can be repeated with again at 2 weeks. If any of the 2 positive, we treat these patients with anti-tubercular drugs, rifampicin and INH. There are standard guidelines for treating these patients. We use rifampicin and INH for 3 months. And if patient only takes INH, which we usually don't do because in our country, TB is very rampant. So their INH is used for 9 months. But it's always better to use 2 drugs together for 3 months if we are planning to give any of the biologics. But when we give rituximab, we do not screen patients for TB. It's only done for JAK inhibitors and anti-TNF agents and tocilizumab.
Another question by Dr. Abhishek. Do we need to supplement patients with vitamin D prophylactically?
No, not really. But here, since this question has come, I would say not to give patients calcium supplement regularly, because what we are finding these days that patients are coming up with high calcium levels, and we know by certain studies that high calcium level also increases the risk of coronary artery disease in individuals. There was a paper published long ago. So yes, vitamin D deficiency can affect the disease activity. This is known. In lupus also it is known that a patient is deficient in vitamin D, more flares. And in rheumatoid also, there are few studies which have shown that patient can have increased symptoms and disease activity. So if patient is deficient, then vitamin D supplement can be given. And if we are not measuring the vitamin D levels, the vitamin D 60,000 international unit, what I do, I give monthly or 2 monthly without a calcium combination.
Some patients where skin biopsy is done associated connective tissue disorders. How sensitive is that skin biopsy?
So skin biopsy usually is helpful in certain specific situation, not in rheumatoid. If patient develops any cutaneous lesion where we are suspecting, for example, vasculitis, their skin biopsy is done. Or patient develops any nodule and we don't know that nodule is malignant, or that is a rheumatoid nodule, or that is vasculitic nodule, there the biopsy is indicated. In scleroderma also, skin biopsy is not indicated routinely. In very, very specific circumstances, the skin biopsy is indicated. So clinically, the diagnosis is made. Skin biopsy for the diagnosis of connective tissue disease, I would say, is not indicated. But there are specific circumstances where it can be done and it is helpful. Suppose we are thinking of scleroderma and there are differentials. Patient is ANA negative. Then we are in a fix whether is it scleroderma or eosinophilic fasciitis. Then skin biopsy is warranted in that situation to make the diagnosis.
One more question in the chat regarding bisphosphonate, they have asked.
Bisphosphonates are not given to patients with rheumatoid arthritis, but as I was talking about the comorbidities, because inflammation predisposes these patients for osteoporosis, and sometimes these majority of the patients, they are on steroids. I mean, that is prescribed from, these things should not be given ideally to all patients. Then a patient can develop osteoporosis. So if the patient is diagnosed as having osteoporosis, then only bisphosphonates are to be started.
Earliest manifestations like mouth ulcers, correlation to the connective tissue disorders.
So oral ulcerations can
After
happen.
ulcers, yeah.
Yeah, aphthous ulcers can occur even in normal individuals once or twice in a year. That is insignificant. Nothing is to be done. But oral ulcerations define certain diseases like Behçet's disease, where patient will have recurrent painful orogenital ulcerations, or in lupus, where patient can have oral ulceration. Recurrent oral ulcerations are one of the manifestations. Patients can have oral ulceration even in vascular ITDs like GPA, granulomatosis with polyangiitis, palatal ulcers are known. So, and then sometimes patients, when they develop infection, maybe fungal infection, they can develop oral ulceration. There could be deficiencies of vitamins and minerals that can result in oral ulcerations. So we really need to see, or if patient has Sjogren's syndrome, where there's dryness of mouth and eyes and dryness, there also patient can have fungal oral ulcerations. Ulcerations can happen in I'm just forgetting, they're just slipping out of mind. That is also autoimmune condition. Their patient can have oral ulceration. And this hyperpigmentation in the mouth, and patient can have oral ulceration, lichen planus I'm talking about. Yeah. So there also patient can have. So that there are very specific situations where patient can present with oral ulceration. Or there's associated IBD in spondyloarthritis. Their patients can present in Crohn's or ulcerative colitis. So patient can have oral ulcerations. So we have to very specifically look at what is the clinical scenario where patient fits in.
There are no further questions in the chat as of now.
Okay.
And one last question. Are there any genetic markers predicting early these patients are going to develop florid? Because diagnosing rheumatoid arthritis at deformity level is not going to help. So how early we can diagnose?
Early with genetic markers, rheumatoid arthritis.
Yeah.
No, which HLA-DR4, I mean, these markers can predisposes individuals to development of rheumatoid arthritis. Right, and they can, in a way, if they're positive, obviously they suggest the aggressive disease, but there are no definite markers, genetic markers, which can actually predict this particular person would have aggressive rheumatoid arthritis for sure.
Thank you.
Would you like to, okay, there is one more question. From Dr. Santosh, apart from the pharmacological agents, is there any role for physical therapy to delay the deformity?
The primary treatment happens to be pharmacological therapy. I did not touch upon the other supportive care, non-pharmacological treatment, which is equally important in our patients. So yes, physiotherapy helps our patients. Then occupational therapy helps our patients, where they are taught how to use their joint, not to abuse their joint, so that there's less stress. And then exercises, muscle strengthening exercises. Then yoga reduces the inflammation. Even we have papers published where we have shown that yoga, along with pharmacological treatment, is better than giving only pharmacological agents. So inflammation was controlled better. Their mental health was better, which I didn't touch upon. So definitely these therapies have got a role in the management. But if somebody says that physical therapy, physiotherapy, occupational, or these therapies without pharmacological therapy, I would say no.
There are no more questions. Would you like to ask the participants or assess the participants through MCQs or anything then?
Yes, I can ask them. So how would they reply?
They can type in the chat. Like if you have a question, they can reply in the chat. Like.
Okay. So I'll ask a question. What is the sheet anchor drug in the management of rheumatoid arthritis? Oh, very good. 2 people have responded. What are they going to get? Chocolates or something? Credit points?
So let us just to give a feedback.
Yeah. Out of the 4 biologics which I would be naming, which does not require TB testing before giving it? Okay. Etanercept, infliximab, tocilizumab, rituximab. Oh, very good. Brilliant people. I won't say my lecture was informative. I'll say they are brilliant. Okay. So then, yes. Tell me, methotrexate induced nodulosis is present, one, or where is it present? Where would you look for methotrexate induced nodulosis? Sites. I talked about rheumatoid nodule. Oh, very good. Away from joint. Where? Away from joint? Oh, no, not bone marrow. I had shown you the picture also. There was methotrexate induced nodule present. Pulp of the fingers usually, hands. Similar positions in the feet. Lung, no. Usually not. Usually not. Rheumatoid nodules are more commonly present in the lung or other organs and on the extensor surfaces like occiput. Cardiovascular, major cardiovascular complications are known with all of the following or none of the following, right? Anti-TNF agents, tofacitinib, baricitinib. Major cardiovascular complications, all of the above. Very good. This is right. Okay, so we'll ask more. The commonest type of interstitial lung disease in rheumatoid arthritis. I would suggest Dr. Parinita and Dr. Sumit not to answer this. Commonest type of interstitial lung disease in rheumatoid arthritis. UIP, very good. Very good. Methotrexate causes interstitial lung disease. True or false? So that is the important message I am able to convey. Yeah. Otherwise, people just stop methotrexate or they don't give methotrexate. They are so scared it does not cause interstitial lung disease. Yeah. So I think.
Great. Thank you so much for the interesting lecture. It was very lucid presentation and the questions were also very interactive. Now I'd like to Professor Ajay Kumar Sood, sir, the Deputy Secretary of the National Academy of Medical Sciences, to deliver the vote of thanks.
Thank you so much. It is indeed my great pleasure to thank the esteemed speaker for this evening, Professor Uma Kumar, for covering a very complex issue of rheumatoid arthritis in a very simple and comprehensive way, perhaps sharing her experience of decades with our participant. Thank you so much, Madam, for being with us this evening. I'm sure that the practical tips which you have given for the management, effective management of rheumatoid arthritis will be of great use to our participant, especially to the PG students for their clinical management. And we look forward for your support in future also. We have also noted that Madam has kindly agreed to be NAM faculty mentor. And that again, I think is a big support to the National Academy of Medical Sciences. Thank you so much, Madam.
Thank you so
We are
much.
also grateful to all the participants. In the participant, I have noted some of senior faculty members who have asked questions and made this session very interactive, as well as the PG students. We are also grateful to our council member. I could find Professor A.K. Sharma, who is our council member. He was also present. And their presence, in fact, has made us a source of encouragement for all of us. And we are greatly grateful to them for their presence in this session. For the student, I would like to inform once again that the next session, which is due on 20th of July, we are going to cover a very interesting topic of management of stroke. So in case you have any question, please send us. We will try to communicate this to the speaker so that these can be covered during the session. Another information for the student, I would like to say that now we have received more than 100 response from various faculty members from all over the country, and they have kindly agreed to be the NAMS faculty mentor. And our IT team, Mr. Ravi and Mr. Anil, have put the brief CV along with their contact details on our website. So all the PG students who want to interact with a senior faculty member from all over the country, they can just interact with them online. And in the guidance which will be given by the faculty member will be useful to them for their career as well as the clinical management. Another information is related to our newsletter. NAMS has started a bi-monthly newsletter, and the next issue is due in the month of August. So I will request all the participants as well as the students, they can share their experience, and we'll be happy to publish them in the next issue of the newsletter. Once again, I would like to thank Dr. Preeti for being with us and coordinating this session so well. We are extremely grateful to you. Our NAMS IT team, which is there, Mr. Ravi and Mr. Anil, has been great support to us for the transmission of this session on Zoom as well as on the YouTube. So once again, I thank all of you for being with us this evening and making this evening so interactive and interesting for all of us. So thank you so much again, and over to you, Dr. Preeti.
Thank you, sir. Thank you all. I declare today's academic session closed.